Prompt initiation of cardiopulmonary resuscitation (CPR) is the key to better survival and lower morbidity after cardiac arrest. Still, survival is low even after in-hospital cardiac arrest of the order of 20%, while it is still lower of the order of 10% for out-of-hospital cardiac arrest. No flow time is the period from the onset of cardiac arrest to the initiation of chest compression. Low flow time is the period of conventional CPR till the achievement of ROSC, return of spontaneous circulation. Need for prolonged CPR reduces the survival. Need for CPR of 45 minutes or more has been associated with an in-hospital survival of less than 2%. It is in this setting that ECPR or extracorporeal CPR with the help of ECMO, extracorporeal membrane oxygenator, comes in for maintaining better cerebral and vital organ circulation. ECMO also gives rest to the heart, allowing chance for recovery if there is a treatable cardiac cause for the cardiac arrest, as by coronary revascularization. A study by Patricio D. and Associates compared ECPR versus conventional CPR. Decision to initiate ECPR was based on the following criteria: age less than 65 years, witnessed cardiac arrest, estimated no flow time less than 2 minutes, estimated ECMO placement time less than 75 minutes, no severe comorbidity, signs of life during conventional CPR. Technical details of ECPR. Mechanical CPR device was used if ROSC was not achieved in 3 cycles of manual CPR. ECMO was initiated by well-trained ICU physicians and or cardiac surgeons. Peripheral femoral veno-arterial ECMO with percutaneous cannulation guided by ultrasonography was done under the support of mechanical CPR. PaO2 was maintained in the range of 80 to 150 mm of mercury. Mean arterial pressure was kept above 65 to 70 mm of mercury with vasopressors and fluids if needed, and targeted temperature management aimed at a temperature of around 34 degrees centigrade for 24 hours were given. Cardiac catheterization was performed if indicated. Anticoagulation with unfractionated heparin was used. ECMO used a 25 French venous cannula and 18 to 22 French arterial cannula. Initial blood flow was 3 to 4 liters per minute and ECMO priming was with 700 ml plasma light. After implantation, leg was perfused with an andrograde single lumen 8 French catheter to prevent limb ischemia. A total of 112 patients received ECPR and 523 received conventional CPR over a 5-year period from 2012 to 2017. The study concluded that ECPR may be associated with improved long-term neurological outcome. In the CHEER trial, mechanical CPR, hypothermia, ECMO, and early reperfusion, extracorporeal CPR could be established in 24 of the 26 eligible patients with a median time of 56 minutes from the onset of collapse. Survival to hospital discharge with full neurological recovery occurred in 14 of them. 11 of the 26 eligible patients had out-of-hospital cardiac arrest, while 15 had in-hospital cardiac arrest. Hypothermia was induced by intravenous administration of ice-cold saline as per their protocol. Percutaneous cannulation of the femoral artery and vein were done by 2 critical care physicians for commencement of veno-arterial ECMO. Those with suspected coronary artery occlusion were transferred for coronary angiography. Therapeutic hypothermia was maintained for 24 hours in the intensive care unit. While conventional CPR provides only about a quarter of the normal cardiac output, ECPR can provide sufficient perfusion to vital organs and reduce the duration of low flow status. Rapid achievement and maintenance of targeted temperature management is possible with ECPR because of the availability of heat exchanger. Another advantage cited for ECPR is the facilitation of coronary interventions even in patients with sustained ventricular fibrillation because VA ECMO provides stable systemic perfusion. Bleeding, limb ischemia, and sepsis are the important complications of extracorporeal CPR. Limb ischemia is taken care of by a distal perfusion cannula to improve distal flow in the femoral artery. The distal perfusion cannula connects the arterial return line from the oxygenator to the distal femoral artery so that a portion of the oxygenated blood is used to perfuse the distal lower limb beyond the point of connection of the main femoral arterial ECMO line.